Thank you, Amy. Good morning. My name is Megha Chakshi, and I'm the Senior Vice President at Government CIO. We all know that seamless care and benefits have become the North Star of federal agencies as they work to create a continuation of healthcare and service benefits for a veteran or a service member when they begin their journey within the DoD and all the way until their retirement. To meet this goal, agencies need to build a secure, data driven ecosystem to accelerate research and innovation and connect healthcare and health data. Joining us today is Bill Tinston, who serves as the Director for the Federal Electronic Health Record Modernization Program Office, or FIRM. In this role, he creates the firm's efforts in implementing a single common federal electronic health record with the Departments of Defense, Veterans Affairs, and Homeland Security's U.S. Coast Guard. Welcome, Bill, and thank you for making the time this morning to meet with us.
Thank you for having me, Megha.
Alrighty, so I'm going to just start with the basics. And can you tell us why is a federal EHR so important?
Well, really, if you look at VA and DoD and the health systems that both of those departments provide, combined, you have the largest medical system or health system in the world, right? And it's the same people. So you have from joining the military to retirement or leaving the military and then their life as a veteran. It's the same people that you're dealing with. And, there's differences in beneficiaries, but you have the same people, and having a common record about that patient, not who delivered the care or where the care was delivered throughout the experience, the military and veteran experience for those individuals is incredibly powerful. It gets the right information to providers so that you can make the best decisions about providing healthcare. Another thing it does is it creates this longitudinal record of a huge population and the insights that can potentially be gained from that set of data about patients and what has happened to them. So looking at the aggregate data, finding insights that you can apply to the individuals as you move forward and delivering better healthcare to them is a very, very positive thing. And creating this single record and creating this common set of workflows within the military treatment facilities and within the VA medical centers, and then combined between them, gives us the opportunity to bring the best practices that those two medical systems can create and deliver them across the board to both systems, and actually all three. I never want to leave the Coast Guard out and their engagement in this. And frankly, as we proceed with the single common record about the patient, are there opportunities beyond Coast Guard, VA, and DoD to bring in other elements of the federal healthcare enterprise into the common record? And I imagine there are. And then I think you'll ask me later about connections to the private sector, and there's really exciting stuff going on there. So that we just create this comprehensive view of the patient encounter experiences to support providers as they deliver healthcare going forward.
So there has been a lot of news recently that the firm, DoD, VA, and then Coast Guard expanded the joint health information exchange to about, I believe, 15,000 provider sites. And so what have you heard from the providers in the field on how this has been going, and have they seen any elevated benefits from that?
So absolutely. And I actually had a really good conversation about this yesterday with the joint HIE team. Is a joint VA DoD firm team that manages this and implements changes. And I'm going to start here. It was really interesting that when we started this journey down the joint HIE path, the DoD and the VA each had an HIE. The DoD, I think, and I've been asking this question for like 2 years, and the fact that they brought me the answer yesterday and you're asking me this question today is fantastic. I think the coverage of the community healthcare providers on the DoD side with the Health Information Exchange was about 14%. Now, we focused on the important 14% where our patients were referred and so forth, but it was about 14%. And if I got that wrong, somebody will correct me later and tell me I'm not allowed to speak again. And I think it was about 30% on the VA side, right, of the community care providers out there. So we started there. We brought the Joint Health Information Exchange. We created that. The two departments created that. They brought the 14 and the 30% together, and there was some overlap there. but they simplified the process, right? It was now one agreement for these health information exchanges, the regional exchange, one agreement with the joint health information exchange, not with the VA and the DoD. So anyway, we combined, we got advantage from that. So all of the VA connections are now shared with DoD and vice versa. Clearly the VA had more connections when we began this. And then you mentioned the 15,000. So that's when we brought in, oh my goodness, what's the, we brought in an additional capability that expanded an additional 15,000, and it created, I think we had about 46,000 connections at that point. And the really exciting thing that the team shared with me yesterday is on the DoD side, they've gone from 14% coverage or so to 65% of the community care providers, and from 30% to 65% on the VA side, which is a huge improvement. And then I don't know if you've ever heard Dr. Evans, who's part of the firm and was the original director and leader of the firm, and he's a provider, talk about what the power of bringing that data and making it available to the providers when they're providing the care, that you have the information on prior encounters that were executed elsewhere is very powerful. So Commonwealth is the name of the capability that we just brought in. That was the additional 15,000 connections, endpoints that and facilities that we're now connected to. So it's been a tremendous success. It's a place. So I like to mention that the J is in front of it. It's joint. It was really good decision-making by the leadership of the VA and the leadership of the DoD to recognize the advantage that they could bring to the two healthcare systems and to the providers, and really to the beneficiaries, the patients, by combining efforts, looking at this as a common set of capabilities that providers in both departments, and all three, Coast Guard gets the benefit of this as well, all three departments' healthcare systems. So this is a fantastic success. And as we move forward, here's the really exciting thing, and this is kind of a common theme in everything we're doing at the firm and everything we're doing with the Common Record. We know why we're doing it, but we don't know some of the places it can take us. And I looked at your preamble speech, and you had Commander Holston there saying, hey, I want to hear what's happening out in Washington. I want to hear from the individual providers. I don't want the best ideas coming from Washington, D.C. I want it coming from out in the field. And that's important. And that will help drive some of the outcomes that we can't even imagine yet. But one of the things that we've seen, because we share data, how do I describe this? We share data with the VA, and we share some data with the VA through the same mechanisms that we share the community provider information through the Joint Longitudinal Viewer and that data presentation capability. And as we've done this with the VA and the DoD at this point, where we're sharing the information via FHIR interfaces, and we're providing much better accessibility and usability to the data. And it's been amazing what we've been able to do there. And we want to take that experience and we want to bring that to the community interoperability side, so that we bring that same data quality, that same data usability, and that same data accessibility on the community provider side, as well as what we've done internal to the federal government.
So you had mentioned Dr. Evans and, of course, a provider perspective that literally, basically, in many ways, this translates to a enhanced patient experience and quality of care.
Right. As I hear him tell it, he gets the information he needs about encounters that are not in the VA or the DoD record, and it's all pre-positioned. The way the JHIE works, it goes out, it works from appointment schedules, and it goes out and it finds all the other encounters, and it makes all of that available. It doesn't make the provider wade through all of that up front, but it makes all of that available to them, because the relevance can be very different. You probably don't want to know about his broken leg from when he was 8, but you do want to know about the encounter that he had last week and the COVID testing that he had, or whatever else it was that is relevant to the encounter that's currently happening. And all of that information is available. And I wish we could hear Dr. Evans talk about it, because his perspective his perspective inspires me to understand that we're doing the right thing here, and we're creating value to the patient and beneficiaries, and to the providers, and delivering the healthcare that they're delivering to our federal beneficiaries.
Well, we'll make it happen next time, right? We'll have
Uh,
you and Dr. Evans together on
yeah,
a panel and then look at it from a holistic perspective. So,
yes,
2020 has really been a pretty big challenge for everyone, right? The business models had to change. Everyone had to rethink on how they conducted business and,
yes,
supported their customers. So
right.
in this case, your customers were the military service members or the veterans. So, and you also mentioned longitudinal records. So from a federal EHR perspective, the available data that you have, how did that help you enhance the healthcare during this COVID-19 crisis?
Yeah, so nobody likes 2020. I mean, it's like having to eat plain celery for the rest of your life. That's all you got. It was not a fun year. Didn't even get any peanut butter. But from a EHR delivery perspective, from federal EHR delivery perspective, amazing things happened and amazing responses to the challenges that the world and the nation faced happened. So clearly, we're back in March and I get a call from, we're starting to understand what's going on. I get a call from my counterpart at the Defense Health Agency saying, "Hey, Bill, we can't go to the military treatment facilities anymore for a couple reasons. One is there's travel restrictions and there's the exposure problems, but the other is that the military health system and the VA did the same thing, right? I mean, the health systems and the providers in those health systems are responding to a national crisis, right? They are not available. You have to do something else. You can't go train those people because even if you could travel there, they're not available to be trained because they're responding. They're in New York or they're in Washington State, and they are part of the national response. So the two programs, the VA and the DoD, they looked around. They said, okay, so clearly I understand where the priorities are, and it's right that I'm going to get out of the way. And so both programs did that. We are not going to bother providers. We are not going to get in the way of the healthcare delivery needs that the nation has right now. So what did we do? We supported the healthcare delivery. What we found is where, and it was very minor. I mean, DoD had 8 sites deployed at that point, and VA didn't have any. But at those 8 sites, we found that we were more responsive. That when we needed a new COVID test became available, and they needed to be able to be ordered through the record, we could make those changes in hours, and it took place across the board where we had deployed the common record. Whereas where we were in the legacy systems, it took weeks and months to make those changes. So we learned very quickly that we were more responsive and we were better where we had the new modern common record in place. So we focused on that. And then we started thinking about, both departments started thinking about, okay, clearly there's been a disruption in our plans. Clearly when the providers are available and we get back to delivering, we can't put it, our training strategy needs to change. We can't put people sitting elbow to elbow in a room and deliver this training to 40 people in person because we can't, because you need social distancing. You can't have that many people in a room. People need to wear a mask, or they just can't be together. So we had to rethink how we deliver that training. But what actually happened is in a virtual environment with as little travel and as little face-to-face contact as possible, the VA and the DoD the two programs figured out how to deliver that training, configure the system correctly, get it delivered, and increase the capabilities as we go forward. So at this point, there are 19 DoD commands that have been delivered. So many more actual facilities, but 19 commands. So they delivered Wave Nellis. They delivered Wave Pendleton. They're about to deliver Wave San Diego on the DoD side. The VA has delivered Spokane and Man Grandstaff. They did the scheduling delivery to Columbus, and now they're doing their planning to get to a full EHR delivery in Columbus. So everyone's caught up. Both of the departments have caught up. We're now a 3-department implementation. I'm sorry, I left the Coast Guard out. The Coast Guard, in the middle of this, delivered their initial sites out in California. 4 sites, their first pilot. So we have all 3 departments using the same record at the same time, and that was during the pandemic. So while 2020 has been an awful year for the world, it's been a great year for these 2 programs, and they have accomplished things that were extraordinary. I have never seen 2 programs IT, enterprise IT delivery efforts accomplish what these two programs have accomplished. And they're learning from each other, right? So the Coast Guard was the first deployment in the no-touch social distance world. So they figured out, with our partners, how to deliver virtual training. And so the VA and the DoD have learned a great deal from that, and they're taking those lessons and incorporating it into their training plans going forward. So the DoD focused very much on getting away from computer-based training. Okay, but now we're doing instructor-led training, but now it's got to be virtual. So how do we structure that? And they figured that out. So it has been an extraordinary thing to watch these three departments figure out how to deliver what's needed at the treatment facilities and the VA medical centers, how to deliver what's needed there, deliver the support and the capabilities to the providers and to the administrators of these facilities in the environment that we're in. I was actually asked by somebody in an interview, they were doing a COVID oral history sort of thing, and the question was, what surprised you the most? And part of what surprised me the most is our collective surprise at the resilience of our people in accomplishing the mission. I mean, they understand. I mean, we're blessed in being in an incredibly powerful mission area. Nobody can argue with improving healthcare delivery, right? I look forward to the person who argues with that one, because they won't win the argument. But our people they've risen to the challenge. They've demonstrated resiliency, and they've kept the mission and the focus on the provider and delivering the right healthcare, equipping the provider with the capabilities to deliver the right healthcare as their end goal. And it is shown through in everything we've done through 2020, and it continues in 2021.
So I wanted to touch on a third leg of a stool in all of these partnership, right? So you mentioned, yeah, so you have the providers, we have the federal agencies and the public sector. So it has to be a partnership across the board. So from that perspective, how has your partnership, the public-private partnership, been moving along, specifically when we talk about interoperability?
Well, so when it comes to interoperability, I want to say one thing up front. One of the things that we're doing with the single common federal record, health record, is we're eliminating, and people quibble with me on this sometimes, but I'm going to say it this way anyway. We're eliminating the need for interoperability within the federal space between VA and DoD because we are using the same record. There are differences in workflows where appropriate, and different care is delivered sometimes in the two, because we do different things in the two health systems. But when it comes to the data about the patient, it's that single record about the patient, and providers in both departments are accessing that same record about the patient, not who delivered the care or where the care was delivered. Now we have to extend that to the community care space. So there's been a lot of effort in that over the years, being engaged in the HL7 groups and the interoperability groups, and Dr. Thompson, who many of you probably know, led the IPO, and that was really the focus of the IPO, and that is now an element of the firm as we go forward. So she leads that work stream for us at the firm and does a fantastic job in defining standards and being the single voice of to those standards bodies to make sure that from a federal perspective and a DoD and a VA perspective, we're bringing the right message and we're getting the right standards in place. However, we talked a little bit earlier about the joint HIE. I think that was really a huge change. The two departments coming together, the VA and the DoD coming together and saying this is important, and it's important to the patients, that we need to take a joint approach to this, and we need to drive the data availability, accessibility, and usability that we need for our providers. And I think the firm, with the support of both departments, is uniquely positioned to drive that going forward. And I think you're going to see huge improvements there. And this is one of those areas where I like to say we've sort of set the foundation, but we don't know where it's going to take us. I sometimes tell that, and I'll do it because people expect it from me now. This is my story about the guy that invented air conditioning, Willis Carrier, right? He invented air conditioning not because he wanted people to be able to live in Arizona. He invented air conditioning because he ran a print shop, and in the summer, he couldn't get the ink to stick to the paper. So he needed to dehumidify his print shop. He was solving a problem. He knew why he did it. It was to get the ink to stick to paper. But what he didn't know is he was going to transform the way people live throughout the world and make Arizona a livable state, right? So people can live in Phoenix now because Willis Carrier couldn't figure out or needed a way to get ink to stick to paper in high humidity. So I think we're doing the same thing in many respects with the federal EHR. We know why we're doing it. We know the value we're bringing right now today. We don't know the power that it will bring to the future and what we're going to be able to accomplish as we get this single longitudinal record about the patient, not where the care is delivered or who delivered the care. It gives us the opportunity, I think, as we get this common set of data, and we're bringing in the community data as well, to get better insights, to bring the right data tools and the right data curious minds that can figure out and visualize through that data important things, maybe generally, but for specific patients and how we can apply it to specific patients. And I just think there's things I can't even imagine, just like Willis Carrier couldn't even imagine that he made Phoenix possible when he made his print shop work.
That's the beauty of disruptive innovation too, right?
Right. Absolutely.
To the next level. So as we wrap up this chat, I really wanted to kind of touch into, you had mentioned 2021. So 2021 and beyond, what is the forum looking at in terms of its initiatives and its priorities? Has any of that changed because of COVID-19?
So probably changed is not right. Reprioritized in some cases. So what are the things, and I saw some of this in the opening comments that you guys were showing. Virtual healthcare delivery, right, has become, it's always been on the plate for, VA has been way ahead of anybody on virtual healthcare delivery, virtual video visits and so forth, and even virtual intensivist support and so forth. But DoD, it has been something, it's been on the plate for DoD to do, but it wasn't the number one priority. Clearly, it became a huge priority. And the Defense Health Agency has emphasized we need a common solution with VA. We need, in this federal healthcare enterprise perspective and EHR perspective, we need a common virtual healthcare delivery framework so that we can work together and support one another. So that's been a huge change. It happened in 20, the realization, hey, this is a higher priority than we realized. We need it now. In fact, we needed it before now, but we need to follow through and make sure we get this common virtual healthcare delivery framework put in place for both departments and for the federal healthcare enterprise. The focus on bringing additional capability faster to the providers in both spaces has been a change that we've seen going forward. A focus on the joint sites and dealing with places like North Chicago, where the two departments work in a very process integrated way, not just an IT integrated way, figuring out how to make that work. And then as you figure out how to make that work, and that's not the only site, that's probably just the most integrated site. We have the same thing in Alaska, we have the same thing in Hawaii. But as you figure that out and you make the IT a non-issue for integrated operations, what are you enabling? And this goes to, Mr. Carrier again. What are you enabling the two healthcare systems to do? What decisions are you allowing them to make about how they want to work together in the future? I don't know what those might be, but it's our job to take IT out of that. So the administrators of these healthcare systems and the providers in these healthcare systems can make the best decisions about how to support the beneficiaries and patients, right? And so I think we're going to do a great job as we address the joint sites, enabling that. So it hasn't really changed anything, but it has changed stuff. I think we're going to, now that the VA has gone live and as they move towards Columbus, I think we have an opportunity to make sure that we're converging on workflows and converging on common solutions as opposed to diverging, right? And I think that's important. And it's important from a cost, and it's important from an enterprise IT perspective. It's important from a shadow IT perspective. It's important from lots of reasons. But I think it's important from a healthcare delivery perspective too, so that we can maybe look at configuration management from a more joint perspective. The firm has, a joint configuration management board, and we make joint decisions. But I think we have the opportunity to really drive towards converged solutions now that the VA has got their first site under the belt and they're aiming for the second site, as they simplify some of the processes that they put in place and the workflows they put in place, looking at that from a common perspective and with converged outcomes, I think is a huge opportunity for us going forward.
Well, thank you, Bill. I thoroughly enjoyed our chat, and I'm actually looking forward to maybe in the next 6-7 months get back together and talk about the converged solutions. And I would love to get Evans's perspective too, right, from a provider perspective on how all this is working out. So
my problem is
yep.
me up. I just keep talking.
No, this has been great. Really thoroughly enjoyed it. So looking forward to our next conversation, maybe in 6 to 7 months. But for the time being, I would like to hand over our next panel to Mike Hoffman and an industry perspective. Thank you, Bill, again. Appreciate it.
Absolutely.